Hi, I'm Dr. Manjunath. I'm a pediatrician and allergy specialist based in Bangalore. When it comes to asthma, it probably is one of the most common distressing problem what troubles every parent. As a pediatrician, you're just not worried about the symptoms control, but you're also worried about airway remodeling. That's one thing which always is kept in mind whenever you're treating it. But the question what we are asking is it the asthma which results in the airway remodeling, or is it the remodeling which results in the symptoms of asthma? Let's dive deep into that. Before we go any further, just make sure that you hit that subscribe button. You also make sure that you like and share it with your friends so that it will motivate me and make me stimulated to make more and more videos. Even in GINA guidelines, they speak about one thing, and that's the clinical remission as well as the pathological remission. What does that actually mean? That simply means the airway remodeling. Prevention of the airway remodeling is one of the most important and primary goals of asthma management. What is the primary mode of treatment in asthma? That is the inhaled corticosteroids. Has it been good enough in controlling the symptoms? Definitely, it is good enough in controlling the symptoms. But is it good enough to prevent the airway remodeling to happen? The answer is no. See, another important thing what happens in asthma is that we always speak about inflammation. How big of a deal is that? Is it responsible for the remodeling? And Castro and Rodriguez, in their longitudinal studies of compiling about 39 studies, what they have understood and analyzed is they have failed to correlate any symptoms of eosinophilic inflammation and the airway remodeling. That means airway remodeling is an unabated situation which keeps on going, whether you are treating the disease or not treating the disease, whether you have given corticosteroids for controlling of the disease or not. The disease remains unabated and it keeps on progressing. Well, what are those structural changes which results in limitation of airflow? One is the epithelial dysfunction and the epithelial changes. There is loss of epithelial integrity and there is decreased epithelial shedding. So what happens is there is more of epithelial thickening as well as reticular basement membrane thickening. And another important thing what happens is changes in the airway smooth muscle. Here you have both hyperplasia as well as hypertrophy of the airways. But in asthma and in airway remodeling, it is the airway smooth muscle hyperplasia which is more a common seen pathology than the hypertrophy is. And then we have the fibrous tissue which goes on increasing, whether it is the fibroblast or the myofibroblast. So that result in this epithelial fibrosis results in the plasticity of the lungs so that it doesn't allow the air to expand and relax in its normal fashion. It becomes more and more plastic. And another important thing what happens is the angiogenesis. There are a lot of platelet derived growth factors, epidermal growth factors, and what they do is to cause the neogenesis and the neoangiogenesis. What the typical understanding of airway remodeling and asthma is its chronic inflammatory disease nature. But multiple studies done over years have clearly refuted that idea that airway inflammation is needed, whether it is eosinophilic or neutrophilic or any sort of inflammation is needed for airway remodeling. So it is neither the eosinophils nor the neutrophils. In fact, neutrophils are a protective factors in prevention of airway remodeling. So none of them prevent any form of remodeling from happening, or rather promote it. It is a constant process what happens. In many studies and in many histopathology studies, it has been very clearly evident that the newborns don't have airway remodeling. Children as early as 2 to 4 years have demonstrated the signs of airway remodeling. That means it is the airway remodeling what happens first and then the symptoms. It's not vice versa. The airway remodeling happens first and then you have the symptoms of asthma. So that is one thing which has been becoming more and more evident. How did actually people get to know? As I said, it was the histopathology which was done in the past, but it has its limitations. That means you will have to sample the entire part of the lung, which is not possible. So it is the CT and MRI or the 3D modules which have been generated, where we are able to cut through the slices at multiple levels and we identify the large airways, medium sized airways, and the small airways. And that's how we are able to identify the changes what result in these airways. And just not that, there has been evidence to say that if there is any mucus plugging, if there is any mucus blockage, it happens in certain airways. And if there are any changes, the bronchoconstrictions and the fixed airway limitations happen, it happens in certain airways. So this says there is a lot of heterogeneity in the presentation of asthma and also in the pathogenesis of asthma. If you're giving methacholine challenge test, it again is patchy. It is not throughout. Only some parts of the lung get affected. What's more important is bronchoconstriction is irrespective of airway inflammation. Even with methacholine, the airway remodeling continues to happen even without any airway inflammation. So what the clear understanding at this point is, the airway inflammation precedes first and then the symptoms. So in human models, what they have understood is, at birth, most newborns do not have any changes in the airways and the airway remodeling does not happen. So as early as 2 to 4 years, people have noted that there is changes in the airway. So remodeling has happened. So it's the airway remodeling first and the symptoms next. So these things are very clear. So what we have understood so far is, airway remodeling does not need either eosinophilic inflammation or the neutrophilic inflammation or any kind of inflammation. It goes on. Steroids are not preventing any form of airway remodeling. It's a continued process. Airway remodeling is a continued process. Symptoms and airway go hand in hand. These are the few takeaways what we have understood so far. We speak about the high-end test, and that is CT and MRI to detect the airway remodeling. Are there any tests clinically by which we can make out the airway remodeling? And that happens by the changes in the FEV1. It is such a simple thing which will tell us, your airway, is it going on to have any continued progression of airway limitation or not? So it is as simple as that. The subepithelial fibrosis is inversely proportional to the FEV1. That means more and more fibrosis, less and less FEV1. What we need to understand from the CT modeling and the MRI modeling and FEV1 modeling is, it is our responsibility as a pediatrician and as a treating physician who treats asthma particularly, we need to know which are those patients who are going to have those airway remodeling. So we need to pick up those people and prognosticate those patients. Is there any way by which we can control the progression of airway remodeling? Let's look into that aspect in the next video. For now, goodbye.